Okay, hello everyone. Welcome to another SonoWebinar by Apprendi Canada. Thank you so much for registering. And my name is Leonardo Faundes. I'm the founder and owner of Apprendi Canada and the SonoWebinars as well. I would like to welcome people from Canada, from the US, and also from Australia. So welcome. Let me introduce you to Ray Lappalainen. He is a recently retired sonographer who practiced for over 35 years in multiple settings. He's a past board member of the CSDMS and OSDMS, and he's also a past president of the OSDMS at the moment. He's also involved as a council member of the CMRTO, the new college for us sonographers, when sonographers became regulated. So it is my pleasure to introduce you to Ray Lappalainen.
Well, thank you, Leonardo, and welcome. It's my pleasure to be speaking today about appendicitis. I'm not sure how many people find the appendix an easy organ to find, but I think with honesty, I think it's an area that often people struggle with, and with practice, you can get much better. And I've had the privilege in my life to work with some great radiologists and great sonographers to help me coach, get coached into doing it better. So I'm going to go over the incidence of appendicitis, techniques to finding the appendix, ultrasound appearances of the normal and abnormal appendix, and then I'm going to get into differentials. So facts about appendicitis. Appendicitis is the most common cause for the acute abdomen. Your lifetime risk of acquiring appendicitis is about 7%, and 15% of patients presenting with abdominal pain in the ER require surgery. In this 15%, acute appendicitis is the most common condition requiring surgery about 37% of the time. So this is an older graph. They typically say that the peak incidence of appendicitis is between 10 and 19 years. But if you look at the study that I've actually linked on the bottom, Journal of Surgical Research, actually the numbers are changing slightly. So the highest frequency of acute appendicitis is still found in the 10 to 19 year age group. However, occurrence in this group has decreased by about 5%, and persons between the age of 30 and 69% or 69 years old have experienced an increase of acute appendicitis by about 6%. So numbers are actually changing. So let's talk about the clinical features of appendicitis. So periumbilical pain moving to the right lower quadrant, nausea, vomiting, loss of appetite, low-grade pyrexia, McBurney sign, which is pain directly over the appendix, localized tenderness in the right iliac fossa, and Rothschild sign, which is basically pain in the right iliac fossa on palpation of the left iliac fossa. So it's interesting, we talk about classical symptoms of abdominal pain, loss of appetite, and fever, but they only occur in about 50% of patients. So you have another 50% where they don't have the classical signs. So it's something you have to be very careful about, you know, not saying to ER, well, the patient doesn't have all the classical signs, because data shows that they only have the classical signs 50% of the time. Another thing is the white blood cells may not be elevated. So you might not have an increase in a white blood cell count in people that have appendicitis. So I've heard sonographers say, well, you know, if the white blood cell count isn't up, then there's not likely to be appendicitis. But data shows that this is not true. You can have people with appendicitis that don't have elevated white blood cell count. So when we're talking about the normal appendix, so we typically say the normal appendix is less than 6 millimeters in AP diameter, but there is research out there that says some AP diameters can be slightly bigger than AP. So it's really important to assess other features as well. And I'm going to get into that further in my talk. The AP size is fairly consistent, but there's a wide variation in the length of appendices. So people say you shouldn't really, at one time you would have people looking and seeing a very long appendix and automatically assuming that must mean that it's obstructed and appendicitis. So there's a good indication to say don't worry about an appendix that's long if it's still normal size in AP. One of the oldest ways of looking at the appendix is a study from Pilert, and that was from 1986, and they talked about graded compression. So they talked about basically, and this is typically what most people use, they use the graded compression technique. So how Pilert described it was ultrasound transducer to compress the anterior wall to displace bowel loops. And you do that very slowly. And again, this is a critical part of doing it. Don't push fast and don't push hard, because once you do that once, the patient is going to tense up and make the rest of your examination very hard to do. So it's a very slow compression with your transducer. When you do that, it permits assessment of the compressibility of the appendix, and it actually pushes the bowel out of the way. And most authors recommend starting with a 5 to 7.5 megahertz linear transducer, not with a high frequency transducer, which again, a lot of people start with a 12 to 15 megahertz. But when you read about the people that have the most success, they're often starting with a sort of a mid-range linear transducer, 5 to 7.5, and then actually going up after that, and some cases, and a lot of cases going down with a convex probe as well. So let's talk about studies. There's been a lot of studies. I'm not going to show you all the studies, but there's some studies that have said that the visualization, now we're talking about normal appendixes, some studies say that you can see less than 5% of the normal appendixes. And other studies say you can see 98% of normal appendixes, and there's every number in between. So again, there's a huge variability. And I think a lot of us, if we're honest, we work in departments that some people will say, you know, they see a lot of the normal appendixes, and others will say they hardly ever see a normal appendix. And I think sometimes our perspective in finding the appendix and how much time you spend on finding a normal appendix, it depends on whether you work with that person's negative about it or the positive about it. So, and that positive person could be a radiologist, or the negative person could be a radiologist or a coworker that, you know, they say, I never see them, and then you get in your head that you're not going to see them. So just I encourage you to spend a little bit more time. And when you start to spend a little bit more time, you actually start to see them. I love this quote by Ralph Waldo Emerson. He basically, what he says is people only see what they are prepared to see. And if you're prepared to see a normal appendix in most people, I challenge you that you actually will probably find a normal appendix in most people. So we're going to talk a little bit about another approach. So I love this definition as well from Albert Einstein. He says, doing the same thing over and over again in the same manner and expecting a different result is the definition of insanity. Sometimes if we're in that 5% rate of only seeing appendixes 5%, and you're always approaching it the same, don't expect that you're going to start seeing more appendixes. So think about another approach. There's lots of different approaches to the appendix, and I'm actually going to show you one that I find to be most successful. It's basically an intestinal approach. We have to remember that the normal appendix is less than 6 millimeters big, so it's a fairly small organ. And a lot of people will say, well, 6 is so small it's hard to find. But if you think about it, when we look up here in the liver, when we look for the common bile duct is 6 millimeters or smaller when it's normal, and we almost always find it. And why is that? It's because we look at the other anatomy, right? So we look at the main portal vein, we look at the hepatic artery, and when we find those with a little bit of focus, we find the common bile duct. Well, if we take that same approach to finding the appendix, we'll find more appendixes. If you take the approach of a lot of people and just looking in the right lower quadrant for the appendix, you're not going to find a lot of appendixes, because the appendix is quite a mobile structure, and it can be high, it can be retrocecal, it can be low in the pelvis. It actually can be on the left side too. Those are hard to find. I like this quote. It says, when you make the decision to do something, make the decision to do it well. And I think if you take that approach to finding the appendix, your amount of normal appendixes that you find will go up. And when you can find a normal appendix, you can be absolutely sure that it's normal. When you don't find a normal appendix, you're sometimes, you know, I'm not sure whether I'm not seeing it or if it's inflamed. So it just changes the way you report the exam. The exam gets reported by the radiologist. So the approach I like to take is an intestinal approach. So basically what I like to do is scan longitudinally or sagittally along the right lower quadrant, along the ascending colon, down to the cecum. And when I get to the end, I turn transversely, look at the ileum, and then when what I really do is focus about 2 or 3 centimeters in that area. And I don't think I find 98% of the normal appendixes, but I know I find over 85% of them. And basically that approach really helps. So basically longitudinally on the ascending colon, you'll see the colon has this appearance that looks like a cobblestone street. So you'll see that, like the Hofstra pattern of the colon. You'll see the bump, 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 the cobblestone pattern. When I get to the end of the colon, turn transversely, and then come back and forth until I find the ileum. The ileum will be very smooth wall. So a paved road appearance as opposed to the cobblestone road appearance. When I find the two areas where they meet, I look very carefully 2 to 3 centimeters to that, and I can usually find where the appendix is coming off. So let's talk further about the normal appendix. So the normal appendix is blind ending. So you can find the blind ending. It's tubular, oblong, layered appearance. You'll see the layers of the bowel in the appendix. It's compressible. So with your transducer, you can push down on it and it'll compress. It's aperistolic, so you're not going to be seeing peristalsis in it. And it's arising from the posterior medial cecum, approximately 1 to 3 centimeters distal to the ileocecal junction. So like I said, if you find that ileocecal junction, which, you know, with practice, it gets quite easy to find that junction. And by doing that, your detection of the normal appendix will go up. So here's a normal appendix in transverse, and you can see with compression, it compresses right down, telling you further that it's normal. So 5, and then with compression, it compresses down to 3. And one of the things that some people assume is that the appendixes are straight. Well, they're not. They can actually be like this one, like a curve. You can see the curve of like a C. Some appendixes are actually shaped like pretzels. So it's important to follow the appendix from the origin at the cecum all the way down to the tip. The tip is often the most inflamed part of the appendix. And the tip, in this case, you will see that the tip is not the lowest part of the appendix. The tip is actually up here, more caudal than this curve in the appendix. So you have to follow the appendix around and be very diligent in following it to the tip. So more studies, it's important to look at the studies. A graded compression sonography examination depicted the appendix in 170 cases of 202 subjects, so 84%. And then they increased their detection rate by adding some additional views. So I have found that by adding these additional views, you really do jump up the amount of normal appendixes that you're going to see. So posterior manual compression technique. So put your other arm at the patient's back and push up on the back by the psoas muscle and push it up towards you. Use a low frequency convex transducer and use an upgraded compression technique, upward graded compression. So not just pushing straight down, but going lower and then pushing up and curving with your hand. So basically up, up, up like that. So, and then this is very helpful, doing left oblique or lateral decubitus change of position. So turn the patient away from you if you're scanning on their right side, and basically scan further to their lateral side behind the bowel. And this really helps with retrocecal appendixes, and it really helps in the pregnant patient because the appendix often gets pushed to the side by the expanding uterus in the pregnant patient behind bowel. But this technique really helps in pregnant patients for finding the appendix. So again, a couple other pictures of normal appendix. So there you see the measurement 5, and here with compression 4. And remember, when you find that cecum, go scan, turn lateral, go up till you find the terminal ileum, and then basically, usually within 3 centimeters or so, you can find that appendix. So if you use that technique to find those two, the cecum, terminal ileum, you can very frequently find the normal appendix. So here you see again, here's a appendix hiding behind the cecum. And we have to remember that with appendicitis, the vast majority of them are appendicitis are caused by luminal obstruction. So basically with obstruction, you get distension, you get an increase in luminal pressure, which causes the patient the pain. You get an increase in bacteria, which often causes that elevated white blood cell count. And like I said, in some cases, they don't have that. So sources of obstruction include fecal lists, or some people call them appendal lists, lymphoid hyperplasia, seeds, in some cases seeds of food that we've eaten. Barium can cause obstruction, and in some cases ingested foreign bodies. And there has been a few studies that have shown people who've swallowed their tongue studs to cause an obstruction of their appendix. So as a parent, you want to say to your kids, don't get a tongue stud, you might end up with appendicitis. So just a joke there. Sonography of appendix. So other things we can look at, the presence of intraluminal gas in the appendix kind of argues against appendicitis, because remember that usually starts from an obstruction. That obstruction causes expansion, and basically they don't usually have air in their appendix when they have an obstruction. In rare cases, they can, if they have a gangrenous appendix, they can get air in it. But usually they have a whole lot of additional findings, which I'm going to go over that in a short while as well. So without the additional findings, seeing air usually indicates that it's a normal appendix. If the patient's bladder is full, it's really critical that you allow them to void and relook for the appendix for a couple reasons. When that bladder gets full, we all know it pushes the bowel up. And when you've got all that bowel pushed over it, you're less likely to see the appendix. And also when you're trying to do the graded compression, if somebody has a full bladder, they tend to tense up. So let the patient completely void. And it's amazing how often when they have a full bladder, you let them void and then you see the normal appendix. Make sure you examine the appendix completely again, as I said earlier, top to bottom. And the tip is often the first area that is inflamed. And the tip is not always the most inferior aspect of the appendix, like I said. So here's an appendix with transversely with a little bit of air in it. And here cecum, appendix with a little bit of air in it, normal appendix. And here's longitudinally on that, a little bit of air in it. Here's an appendix close to the cecum, that's normal in size, and you follow it all the way down. You notice down to the bladder, and you can see thickened fat around it, and this is enlarged to 8 millimeters. That's a inflamed appendix down there, down towards the bladder. So again, critical to follow to the tip. So this is kind of a netter diagram, and basically it kind of shows that appendix can be in different positions. And it's important, if you're using that, the bowel approach, as opposed to the right lower quadrant approach, of just starting here and doing transverse compression, you're going to find more of these appendixes. This diagram shows the multiple different positions that the appendix can be in. And it's important to know that when the appendix is in a different position, it often changes the clinical symptoms. So in a normal location, you often will have that fever, nausea, vomiting, and right lower quadrant pain. When you have a pelvic appendix, you often will have different conditions. You might have diarrhea, pelvic pain, tenesmus, which is the urge to evacuate the rectum or urinary bladder. And retrocecal appendixes often present with flank pain. So you might come across a patient that's referred to you for a possible kidney stone. And if you don't see a kidney stone or hydronephrosis, it should be an indication to you might be a retrocecal appendix, and go looking for that appendix. Because my experience is when you do that, when you have that thought in your head, you will pick up these retrocecal appendixes in those patients that are referred for possible kidney stones. So other techniques that you can use, visualization of a deep abdominal retrocecal appendix can be enhanced by that manually compressing the posterior lateral abdomen, as I said earlier. Turning the patient to the left lateral decubitus helps displace the cecum and ileum medial to help visualize the retrocecal appendix. So often with inflamed appendix, the appendix is sticky, and when you rotate the patient, that bowel will move, but the appendix that is sticky will be adherent, so that it actually opens that area up for you to see those patients. And like I said earlier, this really helps with the patients that are pregnant that you're being asked to look at. So turn them up onto that left lateral decube and actually look from the side, not from the front, for their appendix. Visualization of a pelvic appendix can be aided by upward sweeping compression or by endovaginal sonography. In a study by Caspi, the inflamed appendix was seen 24% more frequently with endovaginal. So let's look at a few of these. So this is a very difficult appendix to see. So this is the CT scan, of course, and you see the cecum, you see the air up here at the top of the cecum, and you can imagine if you were trying to do an ultrasound on this patient and you're looking from the front, you'd be hitting that air and you would see very little because that air would block out this appendix, which is behind there. But if you take an approach where you turn the patient that direction towards the left lateral decube, and you scan from the side, that bowel will rotate, that appendix will actually rotate up, and you can sometimes see behind that bowel. So those retrocecal appendixes will suddenly be very visible on ultrasound. So I'll show you here a case. So it's the patient that we had done while I was working in Brantford. We couldn't see the appendix initially. We rotated the patient, scanned from the side, and you could see the cecum and the appendix here. And then we kind of lost it again because of the bowel gas. But you see here's this cecum, but behind the cecum, you can actually see the tip of the appendix here, and it was nice and normal size, and there was no other findings to indicate inflammation, and we were happy to call that a normal appendix. Sometimes you'll see when you take that bowel approach, you'll find that the bowel is in a different position than the right lower quadrant. So the appendix, in this case, this darkest structure here is actually the kidney. So you can see the kidney a little bit better here, but same patient here and here, you can see the appendix sitting right up at the right kidney with compression. You can see that compressed down. So a normal appendix right at the right kidney. And in this particular patient, was a patient that was referred for cholecystitis, and the sonographer could see a very normal gallbladder. And then what makes ultrasound so good is we can always go to the point of tenderness, and our sonographer went to the point of tenderness and found the appendix right next to the liver here. So an enlarged appendix and a hyperemic appendix right next to the liver. So in this patient, their appendix was right up touching the liver. I'm just going to show you this cine clip. This is another patient that, again, looking for the appendix. They had a hard time finding it, but when they asked the patient to sort of isolate the area of most pain, the patient pointed in the basically mid to left. It's marked right upper quadrant, but it wasn't actually right upper quadrant. It was like, I guess it was mid to upper abdominal area. And basically you see with the cine clip that appendical lith and that fecal lith, and you can see the bowel moving behind it. I'm going to actually run it again. So you can see the bowel behind, but you see this rigid area here. So this was a inflamed appendix that was quite high. And I'll do that one more time. See the bowel moving behind it, and with compression, everything, and that rigidness of that appendix. So appendix often become very rigid with inflammation. Here is appendix that was found with endovaginal. It was a patient that you could see a little bit of free fluid, and then basically with in the abdomen, when we did the right lower quadrant, and then they went to endovaginal, and you could see the inflamed appendix sitting there, and you can actually see the measurement on the bottom one, which is 8.5 millimeters. So right here, and transversely right here. And again, you can see the fat wrapped around that. So let's talk a little bit more about appendicitis and things that can help you find the appendicitis. So our big thing with ultrasound, is it normal or is it appendicitis? So what is the size? So 6 millimeters, some authors say 7 millimeters in AP across age groups is considered the cutoff. What is the shape? This is very important for people to be looking at. So the normal appendix is often oval, and inflamed is usually round. If we go back to our physics in ultrasound, you remember Pascal's law, and Pascal's law says in a closed tube, pressure is equal across all directions. So if it's equal across all directions, then when an appendix is obstructed, it should be round, not oval. So that's actually a good thing to use when you're actually scanning. Is it compressible? And we talked about this. So the normal appendix is compressible, and an abnormal is usually non-compressible because of that obstruction in it. It doesn't compress. Is it mobile? Normal appendixes are usually quite mobile with the bowel, and abnormal appendixes often get sticky and they they get adherent. How thick is the wall? There's been different studies that say that the normal wall of the appendix is less than 3 millimeters, and it gets thicker with appendicitis. I haven't found this one to be that helpful. I found a number of appendicitises that have thicker than 3 millimeter walls, but I also have had a lot of abnormal appendices that that have had walls that are thinner than 3 millimeters, which I will show that as well. Is the wall intact? Loss of definition of the wall suggests gangrenous or perforated appendicitis. Is the wall hypervascular? Hyperemia suggests appendicitis, but in cases of a gangrenous appendix, there will be a lack of flow. So don't use that to be a definite, it can help you say, yeah, it's inflamed, but if you have all the other indicators of appendicitis and you don't have hyperemia, don't say it can't be appendicitis because I don't have hyperemia, because again, if you have a gangrenous appendix, it very likely might not have hyperemia. And what does the periappendiceal soft tissue look like? So very frequently you get this increase in periappendiceal fat, you get periappendiceal fluid, you get hyperemia, that increased blood flow of periappendiceal soft tissue. And I often say to people, turn your gains down, so you're looking fairly dark, and look for the fat, that white increase in that fat. And when you do that, instead of turning your gains up, you actually tend to, that fat tends to jump out at you often before the appendix jumps out at you. In a study that was done a number of years ago, they said patients with acute appendicitis had about 88% of them have colored Doppler in the appendiceal wall. This picture up in the left corner is a red fox, and if you're like me, when I saw this red fox in Newfoundland and Rosemorne Park, I said, that's not a red fox, that's a black fox. And in Newfoundland, the red foxes are actually black. And that's just a reminder to us, don't always believe your color, because like I said earlier, that you can have inflamed appendixes that won't have colored Doppler in them, because when they become gangrenous, they won't have colored Doppler in them. So I worked for a while with a radiologist that used to always say this saying, the secondary findings point you to the primary diagnosis. And I love the saying because in this case, you can see that thickened fat. So cecum here, and you see that thickened fat around the appendix. And you notice here, that's 5.9 millimeters. So, but as you go on, again, that's really close to the cecum. Remember what we said? Look down to the tip, you follow it down, and it gets up to 7.2. Okay, there's the hyperemia, the increase in that vascular supply around that inflamed appendix. And remember I said they sometimes can look like a pretzel. This one was shaped like a pretzel. You see how it wraps right around? Wraps right around. Look at all that fat, all circled around it. And there at the tip, 6.5. And again, all that increase in the flow. And ultrasound is extremely good. Like, you know, this is a pathological specimen, but look how much it looks like the ultrasound. You know, a lot of people are very quick to say, you know, CT is better. CT doesn't see that as well as we do. Like, I really, you know, I'm a real big advocate, you know, if you can, especially in children, children should be ultrasound all the time. You don't want to be radiating children. But even in adults, I think ultrasound should be the first line. We're very good at picking up acute appendicitis. Here's one. Whoop, Let me go back. Here's one that had a thick wall, like wall was greater than 3 millimeters. And again, you see that really thickened fat. And again, the hyperemia. So like I said, this particular finding, I haven't seen a lot, but it is a finding that's been documented in different papers. So it's something to look for. And here again, a big appendix, cecum, okay, terminal ileum, and you can actually see fat around terminal ileum and appendix. So sometimes that's an indicator that you want to look more terminal ileum for something like Crohn's as well. In this case, it was actually just a really thickened appendix. And as we follow that appendix down, you can actually see that that appendix got a bit blurry. And that's when you start to lose the wall definition, that's indicative of possible future rupture of that appendix. And this particular patient, when he actually, by the time he actually went in for surgery, it actually had ruptured. So, so again, you're often, if you're looking, you will see the cause of the obstruction. In this case, a very large appendicolith. And you can see a bit of fluid behind it, and then this thickened material in the appendix after it. Okay, and this one here, you can actually see that the wall is not that thick. It's only like it's less than 3 millimeters, but it was a very inflamed appendix. So there's studies that say if you see appendicolith of any size, or fecalith, whatever you would like to call them, you should diagnose appendicitis. Even if the appendix is the normal size, this one isn't, it's 9 millimeters. But even if you see an appendix that is normal size and it's unless it's freely mobile. If that appendix is freely mobile, they said be careful about calling it. So that's from this study here. So again, appendicoliths, fecaliths, whatever you want to call them, really do point to there being appendicitis. Here's another one, appendicolith. Okay, and just a caution, a lot of our machines, our new equipment have new technologies, and compound imaging, where you have overlapping lines of sight, you often will lose your shadow. So behind this appendicolith, you don't see much of a shadow, and that's often because of the compound imaging that's turned on and comes on automatically on a lot of systems. And just be careful, you might want to turn that off. You'll get a better shadow from the appendicolith. So you can see again, this is like 9 millimeters big. So in larger patients and in patients where the abdomen is too tense to perform a proper graded compression study, it is important to use a lower frequency convex transducer. Again, you can see a nice appendicolith with a great shadow and this tubular structure with thickened fat around it. This large appendicitis in a large patient. This particular patient, you see they started with a linear transducer, and you see this was done at 1044, and then the others were later after that. And basically with this linear transducer, you couldn't make the diagnosis. You see a little bit of free fluid, you see some of the thickened fat, you know something's going on. But when you went to the convex probe, you can actually see this tubular structure that's lost its wall. So it's probably a ruptured appendix, which is important to be communicated, because they deal with those different than unruptured appendixes. This particular patient had a cyst obstructing their appendix in SAG and in trends. And you have to be very careful with patients. Ultrasound, it's been documented, ultrasound sometimes does a poor job when the appendix actually does rupture. So it's very important to get good clinical history from your patient, because as in this case, you see this appendix tubular structure measuring only around probably 5 millimeters. That's probably a little under measured here, but around 5 millimeters. But what you do see is this massive amount of fat around that appendix. So again, the secondary findings are pointing to that primary diagnosis is we have an appendix that's smaller than 6, but you see all that fat around it. And this patient had a little bit of free fluid. And when they actually went to the endovaginal probe, behind the cervix, there was like a massive amount of purulent material, fluid with debris in it that indicated that was probably pus, and that was a patient that had ruptured their appendix. Perforation occurs in about 15 to 30% of cases, and a perforated appendix can result in an inclusive or false study. And again, sometimes this is because the patient, you have difficulty compression because the patient will be guarding. So again, that convex probe will help, and often they will actually have a bowel obstruction. They'll have dilated loops of bowel, which makes things more difficult for ultrasound. So going to the endovaginal in females does help a lot. And often patients will actually say to you, I was feeling terrible a little while ago, but I feel well enough I can go home right now. If you hear that from a patient, think, they might have perforated, because they often will say, I suddenly feel much better. And that should be setting that alarm bell off for you. So this is, again, another picture from Grossmorn Park in Newfoundland that I took a few years ago, and a beautiful boardwalk, which is there. Indirect signs of appendicitis. So this is a study that was done. They had 620 patients. They had 448 cases clearly showed the appendix was inflamed. And in another 160 cases, they saw the presence of indirect signs. So we're going to talk about the indirect signs. So indirect signs are hypertrophy of the peritoneal fat, which I've talked about, sharp pain caused by compression in the right lower quadrant, and localized reduction of intestinal peristalsis. So that's been described as a sign as well. So from this study a few years ago at the RSNA, I found this paper. It said non-visualization of the appendix in the absence of right lower quadrant tenderness and inflammatory changes makes major pathology unlikely. So if you don't see the appendix and you don't see all the secondary finding, it's highly unlikely that the patient has appendicitis. So this paper went on to say the way they report the appendix is critical. So they said, if they just said non-visualization of the appendix, it led to many CT exams being performed. But if they said in their report, non-visualization of the appendix and no other signs of inflammatory reaction, no thickening of the omentum, no free fluid, etc., there was much less likelihood of the patient going to CT. And what I would say is if you can't find the appendix, it's always great to call a friend, because somebody else might come in, hold the transducer a little different, take a little bit different approach, and find that appendix. And if both of you can't find it, again, it assures you that you're probably not missing something. And I think that shows also that you've got a great department helping each other. Call a friend. We learn from one another in ultrasound. So really the role, whenever we're asked to find appendicitis, is our role is basically to identify the patient with acute appendicitis, and to identify the patient without acute appendicitis, which is almost humorous, but to identify an alternate explanation for their right lower quadrant pain. And we're very good at that as well. And ultrasound often picks up all the other differentials, and I'm going to get into those. Again, it's important that you know that increased intra-abdominal fat is not just for appendicitis. So 89% of patients with acute appendicitis will have increased intra-abdominal fat. 100% of patients with right colonic diverticulitis will have increased fat. And you can also see increased abdominal fat if you're looking for it in patients with PID, Crohn's disease, enteritis, and abscess. And very important to know, increased intra-abdominal fat was hardly ever seen with cases of mesenteric adenitis. Because mesenteric adenitis is one of the it's the most common second diagnosis when people are sent for appendicitis. So let's talk about the differentials. So we have right lower quadrant pain. The big differentials is mesenteric adenitis, which is the enlarged and clustered nodes, intussusception, gynecological issues like PID, ovarian cysts, torsion, kidney stones. I'm not going to get into that now. I kind of talked about that a little earlier. Crohn's disease, epiploic appendicitis, omental infarction, Meckel's diverticulum, and mucoceles of the appendix, and some other inflammatory bowel diseases. Ultrasound is, again, I can't state this enough, but ultrasound is one of the best modalities for abdominal pain because we can truly spend time on the area of maximum tenderness. So you can ask the patient, where does it hurt, and spend time looking at that area to see if you can see the cause. So mesenteric adenitis has been reported to be the second most common cause of right lower quadrant pain, accounting for 2 to 14% of the discharge diagnosis in patient with a clinical suspicion of appendicitis. Usually mesenteric adenitis is from a viral intestinal infection, and it basically affects mainly children and teens. As we all know, we have multiple nodes in our body, and when you have a viral infection in your bowel, those nodes will get inflamed. And so to make the diagnosis of mesenteric adenitis, you basically will be directed by the patient. You go to the area of pain, and when you see a number of enlarged lymph nodes, you can make the diagnosis mesenteric adenitis when you see 3 or more nodes that measured at least 5 millimeters in their shortest axis. You have to be careful because sometimes you will see enlarged nodes with appendicitis. It's not frequent, but you do see it. But when you see a normal appendix and enlarged nodes, don't automatically jump to the conclusion that it's mesenteric adenitis. You need to look at other things. You can see this patient, you can see the appendix, and you can see the enlarged node near it here, and the appendix is normal, but don't automatically assume that it's this is mesenteric adenitis when you see an enlarged node, because in this case you would have missed the primary diagnosis. So here's the enlarged nodes, and right next to it you have this bowel that's the multiple concentric rings. And we all know that's kind of the classical appearance for intussusception. So you see all these rings with the color flow in it. And that's a classical appearance of the donut or the ring sign of appendicitis, or no, pardon me, intussusception. So intussusception is invagination of bowel segment, the intussusception into the next distal segment, the intussuscipiens. Frequently there's a lead point like a lipoma, but in our case, that case was lymph nodes that causes the intussusception. And on ultrasound, we can make the diagnosis. So you see the multiple concentric rings in transverse or target or donut sign, and a hay fork appearance in the longitudinal imaging. So just going to show you that. So here you see that kind of hay fork appearance right here. That appearance of the hay fork right here. And I'm just going to run this cine clip And they also call this the sleeve sign. So you see this sleeve sign? See, this is like an arm going into a sleeve. So I'm going to run this cine clip. I can, I'm just having a bit of problem with my mouse here. So I'll run this here. You see how that rolls in and it goes like the sleeve? I'll do that one more time. You see that hay fork or sleeve sign there? And one more time. Rolling in, and there's the lymph node. That's the lead point right there. So in the next picture, you can see that that's that sleeve sign. And then if you look at that concentric rings, you can see how that is the transverse picture right at that level of the red arrow right there, cut across there. And that's that appearance that we see here. So that's the classic picture. Gynae issues often can present for query appendicitis, so PID. This is a classic PID, pussy sort of area, and you can often see the thickened fat around the PID if you're looking for it. And then this patient with a hemorrhagic ovarian cyst referred for query appendicitis. So you can see that spider web appearance of the hemorrhagic ovarian cyst. And again, on these cases, it's really important to crank up your gains, because if you have your gains down too low, like the picture in the left lower quadrant, you don't see that spider web appearance that well. But when you crank up your gains, you can see that. So Crohn's with appendicitis. So the diagnosis of Crohn's can be made on ultrasound with ileum wall thicker than 5 millimeters and color Doppler. You can get Crohn's appendicitis, and so you'll get an appendix that is thickened with a thick wall, but usually they don't have a lumen that is enlarged. So they'll have that thick wall greater than 3 millimeters, like I said earlier, but the lumen of the appendix is not large. So this picture I took out of Diagnostic Ultrasound 3rd edition. And basically this is an appendix. You can see the lumen is not enlarged, but the wall is very thickened. And that they say is the classic appearance of appendix with Crohn's. And it's important to realize that a lot of these patients with Crohn's, if they treat the Crohn's, they actually don't have to take out these appendixes. It'll actually resolve that pain that they're having. So if they treat the Crohn's, it'll resolve that in thickened wall of the appendix, and they don't actually have to go in and take these appendixes out in these Crohn's patients. So typical things on ultrasound that we'll see with Crohn's disease: gut wall thickening, strictures, creeping fat, hyperemia, mesenteric lymphadenopathy, and mucosal abnormalities. So let's look at that. So here's a thickened wall of terminal ileum. You can see the kind of tightening of the bowel there, like over on the one side here, you see the gas and it gets very tight. That's the kind of classic appearance of Crohn's on ultrasound. Here's the increased color flow in the wall. Here's a CT scan. You see the thickening normal wall here with the contrast media. And then here you see the thickened wall. And then here you see thickened wall going into the cecum. So the terminal ileum here, very thickened here as it goes in. And that's the classic ultrasound appearance. And then here you can see, whoops, I got an issue with. They often talk about skip lesions. When we used to do barium studies, they would talk about skip lesions, and you see the arrows pointing at the skip lesions. And those skip lesions are just from the inflamed omentum that you can see here on the ultrasound around here. So thickened fat that actually pushes down on that bowel. And then you get the skip lesions, and you can see here that really thickened fat. And like I said, turn your gains down, and you'll see that white jump out at you. So epiploic appendicitis is another condition, and the epiploic Appendices are small adipose protrusions from the serosal surface of the colon. And these might undergo torsion and secondary inflammation, and they'll cause focal abdominal pain that can simulate appendicitis. So basically, the way this appears on ultrasound is it kind of looks like a white area, like a leaf, as you can see in the picture on the left. It looks a little bit like a leaf. You have to, this condition more often happens in obese patients, and you will see some internal vascularity in this, and you'll see a subtle hypoechoic line. So you can see that subtle hypoechoic line across around that leaf right here. So there again, that leaf, like, I've got a, we're going to go on to this cine clip, and you're going to see that, and you're going to see the bowel in the beginning here. So here's the bowel, and as you get around the area of pain, you're going to see the ultrasound go over that leaf-like appearance thing of thickened epiploic appendage. Whoops, I'm gonna back up one. There it is, see the little bump there? And there, right next to the bowel. One more time. There's the bump. And right there, right next to the bowel. So that's a classic picture of epiploic appendicitis. So omental infarction is another condition, and that looks very similar to epiploic appendicitis. So omental infarction is basically a twisting of the omentum resulting in infarction of the omentum. And like I said, it looks very much like epiploic appendicitis. They typically say the omentum of infarction is usually a little bit bigger than 5 centimeters, and epiploic appendicitis is usually less than 4 centimeters in size. Don't worry about differentiating the two, because both of them, they treat them the same. So they have basically no, differentiating them has no clinical importance. They have a benign history. They'll have the pain. If you identify them, they'll give the patients painkillers and basically tell them to go home, and basically everything's going to be fine when they go home, because it'll basically, that pain will resolve. They do not have to go in and do surgery on these patients. So with diverticulitis, the classical features on ultrasound is a thickened segmental segment of gut, an inflamed diverticula, and inflamed peri and enteric fat, so that inflamed omentum around the bowel. Most diverticulitis occurs on the left side of the abdomen, but occasionally you can get a redundant sigmoid or redundant colon where it will actually flip over to the right, so it can present with right-sided abdominal pain. So a couple pictures to show you what it looks like with the outpouching here and outpouching here. And on ultrasound, you see the outpouching. Often you see the inflamed gut wall, and then that inflamed omentum around the diverticuli. And again, the patient will tell you that's the area of maximum tenderness. So it really is a guided ultrasound to the area of maximum of tenderness, and you can tell with ultrasound that that's what's causing the pain. So mucoceles, also known as cystadenomas, they're rare, but they're very important to pick up. I've only seen a couple in my lifetime, and I'm going to show you both of them. It has a benign and a malignant form. Often it's sausage-shaped or bottle-shaped, and it frequently has multiple layers, onion skin appearance, and it can have calcification in the wall. So 50% present with vague abdominal symptoms and not an acute pain, and 50% with acute pain. So in my series of 2, the patients, 1 presented with the vague abdominal pain and 1 presented with the acute abdominal pain. So I'm definitely not an expert in this, but I've seen 2 that co-workers did, and 1 actually had, was this one here, where the patient wasn't having a whole lot of pain. Actually, you can see the appendix here, and this cystic structure right close to it. And then actually with peristalsis and patient movement, that cystic structure actually rolled over onto the other side of the appendix. So you see it's on this side, and then on the next picture, it's actually on this side. So it's mobile. It moved with the appendix. He was not in pain. He was referred for some other reason for the ultrasound, and this was found. And this turned out to be mucocele. That was benign. So our next patient came, and they had that classical features of the onion skin appearance, that whorled appearance here that you see. And they also had the calcification in it that that they can have. And you can see that calcification here on the CT scan. And this was a patient that was in significant pain. And this one turned out to be a malignant mucocele. So Meckel's diverticulum. Is a true, oops, I'm having issues with my mouse. So Meckel's diverticulum is a true congenital diverticulum. It's a small bulge in the small intestine present at birth, usually within 2 feet of the ileocecal valve. It is a remnant of the omphalomesenteric duct, also called the vitelline duct or yolk stalk, and is most frequent malformation of the most frequent malformation of the gastrointestinal tract. Meckel's diverticulitis may present with all the features of acute appendicitis. So, so it's a true diverticulum of all 3 layers of the small intestine, and again caused by the incomplete obliteration of the vitelline duct. And they talk about rules of 2. Usually you find it in 2-year-olds, 2 feet from the ileocecal valve. It's 2 inches in length, and it's in about 2% of the population. And patients are often asymptomatic. But a couple of cases, I'm going to show you one that was symptomatic and one that wasn't. So patients will present with painless bleeding due to ulcer in that bowel. And they say that, you know, the definitive diagnosis is usually made by nuclear medicine scans. So here's one patient that we had scanned for appendicitis. We could see a normal appendix, and then we saw this next to the appendix. We could see this bowel appearance that was blind-ended with thickened fat. You can tell that inflammatory reaction going around that. This was one that actually had twisted, so he was in significant pain. He was a young 20-something-year-old man, and had obviously had this all his life. And then at this time in his life, it became twisted and caused his pain. He showed up for ultrasound, and you can see it's actually marked. It was actually projecting down into the left lower quadrant. In that lower picture, you can see it's projecting left lower quadrant. Here's one that another patient that actually didn't have any pain in the Meckel's, but we could find a normal appendix, and then this was found next to that, and another patient that had a nuclear medicine scan that showed this was a Meckel's diverticulum. To my last case, and again, this is an interesting one that one of my coworkers did in Brantford a few years ago, and I think is again, it shows the importance of going to where the patient has pain. So this patient presented, a 59-year-old patient with right lower quadrant. He was a very large patient. They referred him for ultrasound. to find appendicitis. The sonographer found a normal appendix and then started looking in the area of pain, and you could see this loop of bowel with this sort of echogenic focus here. Again, as she looked at this, she thought it actually extended outside of the bowel when she looked at that. So then the next picture you'll see is a cine loop, and you see as she runs this, it's a kind of short cine loop. I'm going to do it again. And she's kind of compressing. You can see that it's actually stuck to the wall there where there's something projecting out of the bowel. So the patient then went for a CT scan. And you can actually see on the CT scan that structure actually sticking out of the bowel. So when we actually then got, the patient went back to emergency, and the radiologist had said there's actually something in the bowel and it's actually protruding through the bowel. The emergency physician started talking to the patient. The patient said, yeah, I went to a fast food restaurant and I got a hamburger and I started eating it and I could feel something very sharp. And he said, so I quickly swallowed it. So this Herman cartoon, it says, you know, basically is kind of what happened. He wasn't chewing his food. He swallowed what he tasted as that was hard, and it turned out to be a piece of wood that was in that either hamburger or the hamburger bun, and actually protruded right out of the bowel in that area where you see that little hole right here. So again, this is a very large patient, as you can see from the CT. And ultrasound actually was the one that guided the diagnosis to that. So we're a very good modality in all people. A lot of people will say we're not good in large patients, but this is a case to show you that we're very good in all patients. So that's my last case. I just want to say thank you to all the sonographers and radiologists of Brand Community Healthcare System in Brantford, Ontario that I work with, and to those at McMaster University Medical Center here in Hamilton, Ontario, where I worked for a long time. So, and to everybody I've had the pleasure to work with over my career, I just thank. So with that, I'll take any questions if there's any questions.
Thank you so much, Ray. That was a wonderful presentation. I like all the techniques. I think that's, you know, that targets us in terms of sonographers and getting more onto our arsenal of techniques that we all need for to face different patients. And I agree with you. If you believe that you can find it, you will find it. That has definitely worked for me.
Yeah, I'm a big advocate of that, Leonardo. If you have positive people in your department and they say, you know, we're really good at this, they will encourage everybody else to get very good.
Yes.
If you have those negative Nellies, like I said in that one slide, they will discourage people to spend the time to find them. They'll be in and out of the room in 5 minutes. It's something that you do have to spend the time, and you will find with spending time, you start to see more and more normal. And when you see more and more normal, you can be confident to say it's not appendicitis.
Yes, very true. If you don't mind, I will read it out to you, Ray, in case you can't see it. So it says, I appreciate the discussion. I work in a facility that has said that if you don't see the appendix, it is usually normal. I would like to feel more confident looking for appendicitis.
I think that, you know, the one poster that I had shown from the RSNA, the information about that, it's true that if you don't see it, it's likely normal, but I think you need to go a little bit further and basically, I don't see it, and I don't see any of the other inflammatory changes. That's critical to have on your sonographer observation sheet, and I think it's critical for the radiologist to put in their report, because as that study showed, if they just said non-visualization of the appendix, a lot of those patients are going for CT scans. And that's unnecessary radiation that a patient is getting. So I encourage you to say, basically, I don't see the appendix and I don't see those secondary findings of the thickened fat, free fluid, lymph nodes. So you want to be looking for all those other things. And then that just, when that your report goes out, when you know your sonographer observation goes out to the radiologist, hopefully that radiologist is putting that in his report and will prevent some of those patients from having the CT.
Thank you so much. Thank you for the question and for the answer. Any other questions or comments? Like everything else in ultrasound, it does take a few cases for us to feel more confident when finding those appendices.
Thank you very much, Leonardo. My pleasure.
Guys. Okay, guys. So again, thank you so much for joining us, and enjoy the rest of your weekend. Bye-bye, everyone.
Bye-bye.